see an indentation on the balloon suggesting that we're actually stretching the vein. The patient has pain almost all the time, and in the end we end up with a nice widely patent vein. And usually upstream you'll see less collateralization, less filling of the vertebral system if that was an issue before dilatation. Webs, again, little films of tissues that can cross the vein. In this case, initial injection shows collateralization via the vertebral venous system. Injection a little bit lower down shows this doesn't really project very well, but sort of a transverse web, what appears to be a web. After dilatation, looks much better. Extrinsic compression. This is a lesion up in the upper jugular. Two views of the same thing here. Basically a dilution of the contrast column in this view and actual narrowing, probably the result of the vein sweeping over that lateral mass of the C1 vertebral body. Again, if you balloon this, you end up with not much different than the pre-ballooning image. So this is a lesion that won't respond to a balloon, and if the patient is interested in proceeding with the stent placement, then that would be the way to treat this. It all comes down to risk, benefits, and alternatives, and usually before we start the procedure, we get a good idea of exactly what the patient is looking like. Do you want us to open up the veins no matter what we have to do? Are you someone that doesn't want a stent? Are you someone that doesn't mind having a stent? It all comes down to a conversation between the interventionalist and the patient. Same sort of patient, extrinsic compression, very characteristic appearance. Injecting above the lesion, you see collateralization via the vertebral veins and filling up the venous sinuses with no flow through the jugular vein. And after stent placement, widely patent vein with resolved collateralization. Sometimes it's difficult to get into the jugular vein, especially if it's small in caliber or has a high-grade stenosis at the junction with the innominate vein. In this case, I went up and tried to catheterize the jugular vein. I spent about a half an hour, 40 minutes trying to get in there. Used a variety of different catheter and wire combinations. Was unsuccessful and elected to come from the arm. And here you see the catheter coming from the arm. In this case, there was a very stringy, thready jugular vein with narrowings throughout, especially at the origin. And it came off at sort of this reverse curve, the same sort of on the same trunk as the thyroidal branches. From the left arm, was able to easily get into the vein, ballooned basically the whole thing. There were large segments of stenosis in the upper and lower portions, and ended up with a reasonably good result. Sometimes, again, it can be hard to find the jugular vein. Another trick that can be useful in finding it is actually going up the external jugular vein and injecting hot in the high external jugular, which allows filling via retrograde flow of the internal jugular. You can see sort of a ghost of the internal jugular back there. With that roadmap, so to speak, it's easier to catheterize the internal jugular, relatively high-grade stenosis at the lower end, ballooned it, and end up with a nice result there. The alternative to this would be, and this is a problem that we see not uncommonly, but the alternative would be to directly stick the jugular vein with a needle, run a wire down the jugular vein, and snare it from below, and then come up and run a balloon up into the jugular vein, although that's a little bit more cumbersome, I think, than just coming from the arm or injecting the external. Stent recanalization, sometimes stents do occlude. In this case, there's a catheter, actually a sheath within an occluded stent in the right internal jugular. You can see a contrast around the occluded stent. We cross the occluded stent, which is sometimes feasible and sometimes not, depending on how long the stent has been occluded and how organized the thrombus is. In this case, injecting above the stent, collateralization again via the vertebral venous system, no flow in the jugular vein. And this is a stent that opened nicely by ballooning the length of the stent with a nice widely paid lumen following stenting. It doesn't always work out this way. Sometimes you require re-stenting or stenting within the previously placed stent. Some people have tried stent grafts or vortex-covered stents for this sort of issue, but there's no great solution for stent thrombosis except for maybe changing the anticoagulation profile following stent placement. Again, sometimes we just can't get through these stents. One of the problems is that the stent's been occluded for a long time. The thrombus tends to be kind of rubbery, and so it's hard to get into the stent, hard to get across the stent with a wire. In this case, multiple contrast injections to pacify these thyroidal branches and vertebral branches, no pacification of the jugular vein. Frequently in this situation, we'll put a long sheath up to the base of the vein, which allows us a little more pushability, because if you don't do that, the catheter has a tendency to buckle into the right atrium and cause arrhythmia and fall out of position. But in this case, we're only able to get the stent open. The only other option here would be to try to stick the jugular vein above the level of the stent and try to come from a retrograde fashion. Pelvic veins don't seem, for us at least, to have been a big problem with people, with our patient population at least. A lot of people with MS complain of lower extremity swelling, but I think we've only had a handful of people that had what looked like hemodynamically significant stenoses within the iliac veins. Here, very normal-looking iliac veins in the cava. The concern is this May-Thurner syndrome that Dr. Dake talked about previously, or the crossing of the right iliac artery over the left iliac vein, which causes compression, collateralization, and is really only relieved by stent placement. But that doesn't seem to be it hasn't seemed to be a big problem for us. Okay. Complications almost done here. The issues are, the most common issue we've seen is basically the groin hematomas, which have been self-limited. We worry about these other issues, which haven't been big issues. The main concern is intracranial hemorrhage, which you see here. Again, there's been a couple of reports in the literature. We haven't had that problem in stent migration. This is a case of a very diseased internal jugular vein, collateralization due to the vertebral system, lots of stenosis throughout the vein. Dilated the vein with a relatively good result, but ended up with a little bit of thrombus. Tried to macerate with that with a balloon and ended up with a vein that eventually just clotted off completely. That required TPA thrombolysis and Fogarty balloon thrombectomy. Ended up with a nice result in the end, but this was a case that happened before we started heparinizing people. In conclusion, CCSVI treatment is a safe procedure which is not usually technically challenging for experienced operators, and further study is indicated to refine our techniques and to determine our procedural endpoints. Thank you.